Hi, I'm this year's Pennine area coordinator, and I'm also a third-year pharmacy student at the University of Manchester. So to start off, I wanted to give a background as to like why I chose this topic, the topic being improving autism accessibility in healthcare. So basically, at the moment, it's the UK Disability Awareness Month, and this year's theme is all about access. Now, I feel like sometimes we tend to not be like that aware about like the invisible barriers that autistic patients could face within healthcare. So like according to the National Autistic Society, 1 in 100 patients, like people in the UK, are on the autism spectrum, and that's like around 700,000 people, like adults and children in the UK. Now, if you like think about it, you know, we've all had to go to the pharmacy, we've all needed to access healthcare at some point, whether it be for minor ailments or for surgery. Like it could be something so minor and so serious, but they will need healthcare at some point, you know. And I feel like our job as pharmacists, especially as like community pharmacies, for example, they're like one of the most accessible ways for people and patients to access healthcare. It really is kind of our job to make sure that patients who happen to be autistic receive an equal and also a supported treatment. Now, let me try and share the slides for tonight's schedule. Yeah, so breaks will be provided, as you'll see in the schedule, and everyone attending will get a certificate. So if you guys want to like get to all know each other and, you know, make some friends from this webinar, you can use this hashtag on Twitter or even on LinkedIn. And, you know, then anyone else like seeing the hashtag, you guys can get to know each other. It's a nice way, you know, it's the best we can do in the midst of a pandemic. And if you guys have any questions, feel free to drop it in the chat box or in the Q&A box, you know, ask away. This is really what the webinar is for, to make sure you guys learn. And if you guys haven't looked up on the schedule yet, so this is the welcome presentation that we're doing right now. And then we'll start off with Helen Bowden. She's the CEO of like I Am Celebrating Autism in Greater Manchester. It's a great charity. You guys should look up more into it. Then it's a break, and then we've got David Branford, he's a chief pharmacist for Derbyshire Mental Health Trust, and he'll be talking more about also about like what autism is, but also about policies that have like helped autistic patients throughout. So you guys will be learning about that. And then another break, and then Danielle Adams, she's a mental health pharmacist who specializes in intellectual disabilities, and she'll be talking about medicine's optimization. And then by the end, if you guys have any questions, so we will be talking a bit about the liaison officer and the representative applications. You guys all should have gotten like emails on it. So if you guys have any questions, any queries about it, you can ask in the end. And yeah, without further ado, if Helen is ready or available to give her presentation.
Yeah, I'm here. So whenever you're ready to pop it up for me. So, Sars, you were gonna show my presentation, I think.
Yeah, I'm just bringing it up right now.
Having a minor panic, just a minor panic.
Yeah.
Perfect. Thank you very much. So thanks for the introduction, Sars. Yeah, I'm Helen Bowden and I'm CEO of the charity I Am Celebrating Autism in Greater Manchester. So I'll say a little bit about what we do and who we are at the end. So would you like to move it to the next slide for me? And the next one, thanks, Sars, that would be great. So what is autism? I mean, I think one of the things with autism is that there are many myths and misunderstandings. So first of all, what I thought would be helpful is to kind of go through the basics of what it is that we're talking about. So next slide, please. A common feature of autistic spectrum conditions, and note we call them now conditions, not disorders, are challenges with social communications. Individuals may find it hard to interpret both verbal and non-verbal language. So things like tone of voice, sarcasm, play on words, humour, all of those sorts of things are particularly, or can be particularly difficult for individuals to interpret. Some ASC people may be non-verbal, but actually many have good verbal skills. And what you might notice is that they may use language that includes highly complex vocabulary or may seem overly formal. So the sorts of other challenges that are included potentially are taking things literally and not understanding abstract concepts or language that is slightly less clear or transparent. So this might have implications, for example, in explaining the side effects of medication, in the use of language such as in rare cases or in very rare cases, such as we've certainly heard in the media with regard to the vaccine for COVID. Use occasionally, take after food. What specifically do these phrases mean? They may seem obvious to us, but they need to be more specific. I mean, how much food? What is occasionally? What is rare or very rare? So all of these things can be confusing. Individuals may also need extra time to process information or answer questions. So keep this in mind if you're discussing or explaining complex instructions or information, because they may need extra time to assimilate it. Something that we do see occasionally with autism is repeating what others say to them. This is called echolalia. So just because a patient repeats something back to you, it might not mean that they understand the information fully. So all of this can mean that communications can often be misinterpreted, or they may not be able to adequately express how they're feeling, especially if in a stressful or unfamiliar situation. For example, if the environment's unfamiliar, if they're talking to people they don't know, if they're feeling very unwell, or certainly if they're trying to explain and articulate how they feel. So thinking about sort of your environment where you'll be working, that would be quite alien to many people with ASC. Next slide, please. So autistic individuals may also have difficulty with reading other people. So recognizing or understanding others' feelings and intentions, and also expressing their own emotions and feelings. This can make it very hard to navigate the social world. So individuals may appear to be insensitive. For example, they might talk about highly personal information when in an open environment, or indeed they may make personal comments about you or people that are around them. They may seek out time alone, particularly when overloaded by other people. For example, if the environment is busy, it might be helpful to find a quiet space to discuss things that are important. Sometimes people may not seek comfort from other people, so they may not actively seek support, even if they need it. And that's kind of worth bearing in mind, because we have an anticipation that if people need help, they're asked for it. But this isn't always the case. So we just need to be aware of that. Sometimes people may appear to behave strangely or in a way thought to be socially inappropriate. So this could, for example, be when queuing, they may get very impatient or seemingly angry and very frustrated, and certainly will articulate that possibly. Also, sort of talking in an open environment about personal conditions, and possibly also listening to other people's personal interactions and commenting on these. Some individuals may also find it hard to form friendships, but they may sort of find or think that they've made a friend, which is actually a professional relationship. So sometimes the boundaries between relationships are also slightly blurred. So if you're particularly supportive and helpful in a professional role, then that may be misinterpreted that you are now their friend, and vice versa. So worth again just bearing that in mind. Next slide, please. With its unwritten rules, the world can seem incredibly unpredictable and a confusing place for some autistic people. This is why sort of individuals quite often prefer routine. So they know what's going to happen, what's coming next. They may, for example, want to travel to the same place in the same way. They may wear the same clothes or eat exactly the same food or use exactly the same brand. So in terms of medication, it may be that there is a reluctance to change medication or when or how they use it, even if it's the same medication, but for example, a different brand. So, as I say, that just things to bear in mind. Some individuals may also repeat movements. Hand flapping and rocking are ones that people most often talk about, but actually it can be the repetitive use of an object, such as twirling a pen or opening and closing a door. It's quite often because those behaviours help the individual to calm themselves when they're stressed or anxious. And also quite often they might find it enjoyable. So if this is observed when you're with somebody or working with somebody or during a consultation or a discussion, you might notice that they're constantly seeming to move or fidget. And again, you might think that they're not paying attention, but actually it's just a manifestation of the fact that they're anxious and stressed. Changes to routine can also be very distressing and can lead to high levels of anxiety. It could be, like at the moment, having to adjust to big events like Christmas or changing work or facing uncertainty, or it could be something simpler like the bus has made a detour. All of that change, whatever it might be, can trigger high levels of anxiety. So it may be that an external change unrelated to what you were doing will actually impact on the individual and how they behave or cope when they actually get to you. Next slide, please. So one of the things that gets sort of a lot of coverage, which is quite often falls into one of the myths, is that many autistic people have highly focused interests, and often from quite a young age, although the interests change over time. Autistic individuals can become experts in their special interests and often like to share their knowledge, but they may fail to recognise when somebody else isn't interested or when they're bored or again when it's inappropriate. This can also include their own health. So it's quite possible that some individuals will be very knowledgeable about their own conditions or may indeed research medications. So what I would say there is be prepared to answer some complex questions. Like all people, autistic individuals gain a huge amount of pleasure from pursuing their interests, and they're very much a fundamental part of their well-being and happiness. Certainly it can help people do well academically and in the workplace, but one of the challenges with this is that an individual can be so engrossed in a particular topic or a particular activity that they neglect other aspects of their lives, including health and well-being. So some of the work that we do at IAM is actually supporting individuals who are immensely successful in one sector of their life, but actually chaotic in another. So, for example, we have a very eminent professor that we support who just can't sort of manage his personal finances and his bills just because they have zero interest for him. So you kind of get these sort of quite extreme opposites in some cases, where somebody can be massively capable and intelligent and really engrossed in one area, but actually to the cost of neglecting others. Next slide, please. One of the, I've actually moved that one on. I'll come back to that one in a minute. Can you go on to the next one for me? Yeah, that's great. So one of the things around autistic spectrum conditions is that quite often the focus is massively on the negative traits of autism. It's very much about what people will struggle with, what they can't do, what they need support with, but actually there are many, many positives as well. So, as I say, people can be passionate about interests. This passion often leads to a really deep understanding of the subject, far deeper than many others will have. And it's no wonder that many of our great thinkers are on the spectrum. People think that interests might be very limited, but actually that isn't necessarily the case. Quite often there's a variety of interests and the really strong ability to hyper-focus on these interests. It often means individuals are tenacious, determined, and when other people would give up, somebody with ASC will follow through on things that interest them, meaning they can get great success, and certainly they don't worry about being uncool. Individuals are very honest. You know, if you want an honest opinion, then this is where you'll find it. And in today's world of smoke and mirrors, honesty is really invaluable. Working with somebody who is really straightforward actually is extremely refreshing, although sometimes this directness can be perceived as them being blunt. The thing to remember is that there is never any intention to hurt another person's feelings or manipulate or bully. None of those things, you know, are very much involved in ASC. So in some ways it cuts through, you know, all of that daily communication nonsense that we all endure. And when we really want and need a straightforward answer from somebody, these are the individuals that will be able to provide it. At the heart of what all of this means is essentially neurodiversity, which is simply processing information differently, taking a different view, seeing things from a different perspective are all invaluable attributes. Without these abilities, we would likely never see sort of new innovations or make the big breakthroughs. And certainly ASC individuals have the ability to sort of visualize concepts and ideas and see patterns and things. And also an ability to be really good at the details. So whilst coming up with the big ideas is great, they're pretty much useless unless you've got people who can actually follow through on the detail and make sure everything is considered. One of the biggest myths is around memory, and whilst individuals certainly do have a really good memory, and that's particularly the case where it's to do with a particular interest. That said, if something isn't of interest and they find it particularly boring, then they're quite likely individuals may not engage with it. So, and I think the thing to remember with these positives is that it's interesting to consider that if we were to rephrase them in negative terms, such as obsessive, rigid, lacking social skills, we are actually describing the same thing. So language and the way that we use it in relation to ASC is really important. It can help us to value individuals, but if we're using the negative terms, it also can cause us to label and devalue those same skills and ultimately the individuals who possesses them. I suppose ultimately it depends on from which end of the telescope you're viewing them, along with the environment in which individuals find themselves. So next slide, please. One of the biggest things that we find with ASC is that there's huge amounts of research around mental health and numerous surveys. So a Mind survey quite recently identified that around 70% of autistic individuals experience mental health issues. And also in a survey by Amaze, 42% of respondents said that they felt that they were not listened to or taken seriously. And 52%, so just over half, felt that they had negative experiences when accessing services. And a third felt that practitioners had inadequate autism knowledge. So one of the most common features of around mental health with autism is anxiety. It's a very common challenge experienced by people with ASC and can have a significant impact on daily living. So there can be sort of fear of rejection, certainly fear of asking for help, limiting self-expression, even limiting activities such as going shopping for food, eating in public, using toilet facilities away from home. And all of those things can mean that somebody becomes very reluctant and very anxious in those situations. Hyper or hyposensitivities can lead to the individual avoiding situations where they may feel uncomfortable or anxious. They may also worry about the wider world, and certainly at the moment we're finding that a lot of the individuals that we work with are massively anxious about COVID because they're bombarded by constantly negative and sometimes sensationalized stories. The Mind research also identified that though a diagnosis of ASC helps the individual to make sense of things and understand their situation, specific support that understands both aspects of ASC and mental health was still severely lacking. And so ultimately, as I say, if you want to move on to the next slide, please. Sorry, Soz. You know, all too often these issues are ignored, brushed aside, and quite often seen that as mental health issues and anxiety are a normal part of ASC. This anxiety is real and crippling for the individual, and nobody should have to suffer from it. But equally, it shouldn't be normalized in the context of ASC. Many of the individuals that we work with have massively fulfilling and satisfying lives, and really, you know, live their lives to the full. But certainly where anxiety is taking over, it can cause real physical symptoms such as disturbing sleep, stomach upsets, and ultimately, in the worst cases, can lead to breakdown, self-harm, and even suicide. So setting all of this in context, we now need to look at the sensory aspect of ASC. So it's estimated that between about 45 and 95% of people with ASC experience challenges with processing sensory information. Sometimes people may experience hypersensitivity, be oversensitive to things, while other times they may experience hyposensitivity and be undersensitive to things. Any or all of the senses may be affected, but certainly this is a very individualized situation, so we can't generalize about this, but you kind of need to be aware of all of the aspects of it. So the sensitivities may relate to things like touch, taste, smell, light, colours, temperatures, or even pain. For example, at the moment in shops where you've got Christmas music, some people, you know, we're able to block it out, but for others, particularly those with ASC, it can be unbearably loud or distracting. It can cause anxiety or even physical pain. You know, some autistic people prefer not to hug due to the discomfort of physical contact, and that might be misinterpreted as being that they're cold and aloof. It can be to the point where autistic people avoid everyday situations because their sensitivity is so great that everything is just, you know, on bombarding and overwhelming in those situations. So next slide, please, Saz. So sensory challenges can include vision. So some individuals may have an excellent eye for detail, but this can also lead to some visual things being distracting. For example, the environment. If you're in an environment that has lots of brightly coloured items on shelves or very bright lighting, it might mean that they focus on things like the packaging of an item, or become very sort of distracted by what's going on around them. With regard to hearing, some individuals may find noises very uncomfortable and very distracting. Some individuals actually prefer really loud noises or music. Again, if talking to an individual, it may be that the environment will very much impact on their ability to focus on the information that you're trying to give to them. Some individuals may find some smells really unpleasant. So if you think of the worst possible smell that you could ever think of and times it by about 100, you'll be somewhere close. The challenge here is that some of these things that are really difficult for individuals are everyday things like food or perfumes. So if some medication, for example, has a particular odour, it could be particularly disturbing. Likewise, even if you're communicating with somebody wearing strong perfume, that could be highly distracting and make the environment uncomfortable. And certainly some medical environments have a particular odour that might be problematic. So all of those things can lead to people being anxious in that situation and therefore avoiding those situations. Some individuals may dislike the feeling of things like clothes and might not like to be touched. Certainly some others prefer sort of strong pressure, such as heavy clothing. But certainly within a health setting, this can impact on things like physical examinations, even something as simple as a wound dressing, taking a temperature, a blood pressure cuff, or putting cream or ointment on could be profoundly uncomfortable or even painful. This can mean that some individuals struggle also with things like self-care, such as washing, having a haircut, brushing teeth. The sensation of all of those things can be really disturbing for an individual. One of the things we see with a lot of children is they hate having their haircut. Talk to any parent of an autistic child, and going to get your haircut is probably one of the most challenging experiences they have. Next slide, please. Oh, have I missed one? Seem to have missed one. Have we got taste? Anyway, I'll carry on talking about sensory in a minute.
Is it the slide that I put up in the beginning and then you're like, oh, I'll go back to this
No,
later?
there should be one on taste, but it doesn't matter.
Oh.
I'll get to girls and ASC in a minute. So some individuals dislike certain flavors, and again, then it could be that particularly the taste of medications. The proprioception, this is the awareness of our bodies. So some individuals may have challenges with understanding and coordinating their bodies. They may appear clumsy or uncoordinated. And this could impact on things like physically being able to swallow pills or measure out liquid medicines. It can also, again, this one very much impacts on things like being able to wash or dress effectively. In fact, anything that requires good coordination, and you'd be amazed how much coordination self-care takes. Vestibular, this is our sense of balance and movement. So sometimes individuals enjoy the sensation of particular movements, so may repeat the same movement or may find some movement cause the sensation of motion sickness and are therefore unpleasant. So some individuals genuinely don't like traveling on buses or trains or in cars because they get terribly travel sick, which is to do with this. Interoception, this is the awareness, and this is a really interesting one. This is the awareness of what's going on inside our bodies. So some individuals may be less aware of feeling hot or cold or hungry or thirsty. Or alternatively, they might be particularly sensitive to disturbances in their bodies and become highly focused on these. So in this context, individuals may appear to focus on their health very closely and seek very frequent reassurance or assistance with things that are seemingly trivial or minor health changes. Whilst on the other hand, some individuals may completely ignore major issues of pain or discomfort, and as a result may delay seeking attention until something's got quite bad. So within the context of the environments you are working in, this is a particularly interesting one to kind of keep an eye on. So with some individuals who are very focused on their sort of body and their health and the workings of their body, they kind of may come across as being sort of quite hypochondriacs, I suppose, for want of a better word, but equally there'll be others who kind of rock up with really quite significant issues that they've just kind of ignored. So it's a really interesting one. The impact of sensory challenges, though, and this is really important, will be different from everybody. And it can be really difficult for those without autism to understand why an individual is reacting to something in the way that they are, that may seem particularly extreme or unusual, but we're not experiencing this in the same way. It can, as well be difficult to recognize that the behavior is related to ASC, because all too often, it's written off as being, difficult or different or, making stuff up or needy or whatever other label you want to put on it. So I feel that in this terms, there's a lot of lack of understanding. We can go through and say it's this, that, and the other, but actually in real terms, the impact of sensory challenges is massive on day-to-day living. For some individuals, the overload can become intolerable and they can become incredibly distressed. But also we need to consider that the fear of situations that could lead to sensory overload can lead to massive anxiety and avoiding those potential situations, therefore limiting an individual's life opportunities and experiences. So these issues really need to be treated with respect and really not kind of fobbed off. It's very helpful to discuss these with the individuals and find out what it is that they're experiencing challenges with, and to maybe build up a profile of kind of likes and dislikes and behaviours that indicate where hyper or hyposensory challenges are occurring. So next slide. So I'm just going to talk very briefly about girls and ASC, because this is an increasingly and quite rightly an area where there's a lot of discussion at the moment. So we're seeing a greater awareness that autism in girls and women often manifests differently, and as a consequence, it's not picked up. So this isn't new, by the way. There's a lot of hype about it at the moment, but it's not new. So some of the earliest researchers actually did identify it, but they didn't pursue it. They focused largely on boys instead. And the result of this is that the diagnostic criteria and assessment methodologies that inform what still happened today sort of became skewed towards identifying autism in boys. Even many of the stereotypes that are portrayed around autism are in fact male. And interestingly, as a result, autism in girls is often identified later in boys. So where does this leave girls and women? Potentially, one of the key gender differences is social motivation. Research by Sedgwick in 2016 showed that autistic girls showed similar social motivation and friendship quality to non-autistic girls, whereas boys didn't. It could mean that girls have greater social motivation and they're therefore developing better social skills because they're practicing them more. That isn't to say that there aren't the same underpinning social and communication challenges, but instead girls learn to mimic the social behaviours of those around them in order to fit in, essentially camouflaging and masking the underpinning challenges they're experiencing. The key difference, though, is that social skills are not intuitive in the way that it would be for an individual that is not autistic, but instead effort, and often great effort, has to be exerted to develop and maintain them. And sad to say, some old-fashioned use of gender stereotyping may also mitigate against the identification of girls. So many ASC girls are labelled as shy, which is in effect describing social difficulties. They may be described as nurturing and caring, as they prefer friendship bonds with those who are younger than them. Whilst it's quite often not seen as being unusual in girls, when we see the similar sort of behaviours in boys, and there are lots of other behaviours as well, not just those, boys tend to sort of stand out and become more visible, and therefore subject to closer scrutiny. Next slide, please. The potential impact is huge. So camouflaging may well solve an immediate problem of fitting in, but it can cause great anxiety and be exhausting, leading to mental health issues. So imagine having to carefully watch and plan for every social interaction. The effort is huge. There's also the potential for friendships or relationships that are not healthy, or social naivety that allows other people to take advantage of the individual. Many girls and women pass under the radar of identification throughout their lives. And it could be said that if they're happy and fulfilled in their lives, then is this a problem? For many, maybe not, probably not, but for others, possibly yes. A diagnosis can certainly provide answers to why things like change creates anxiety, and why relationships have been problematic. It can also provide a sense of self-understanding, particularly where there's been negative events for which they blame themselves or for which they feel guilty. It provides an explanation. Next slide. So what we need to think about is awareness of ASC within all health settings for all ages, and understanding that reasonable adjustments may be necessary to take account of all of the sensory and other issues. We also need to understand the impact that ASC can have on parents, families and carers. understanding the complex relationship and experiences of people with ASC in healthcare settings, and particularly around mental health, and not see mental health and anxiety as being an inevitable part of ASC. There certainly needs to be fast referral routes, particularly if hyposensory issues are present, and greater focus on the positives rather than the negatives, and also harnessing those positives to actually build support and manage health conditions. Next slide. Nearly finished. High functioning ASC is often not identified, and individuals are quite often seen as an enigma. Girls are frequently missed or mask their difficulties, which frankly is mentally exhausting for those individuals. And quite often girls and women kind of reach a crisis point at some point in their lives. Sensory issues create massive challenges, quite often in really unexpected ways, for those who are not familiar with them, and for those who are not don't have ASC. If you're thinking that somebody does have ASC, then it's really worth sort of considering and getting expert advice. However, and this is a massive caveat to all of this, everybody will be different. Each individual will be different and should be treated as an individual. And that's why sort of person-centered approaches are the most effective to support individuals with ASC. Next slide. Just a very quick of what we do. So at IAM, we provide one-to-one support for individuals, helping them to develop skills and strategies that they need to get on and live happy, fulfilling lives. We provide outreach support, which may be short-term support to individuals with particular things. So, for example, it might be accompanying somebody to a medical appointment. It might be helping somebody to manage, I don't know, public transport. It could be anything. We had one this week of somebody who wanted to go to Debenhams before it closes, and they were highly anxious of getting there on their own because of the COVID thing, so they wanted some support. We provide support for education and service providers. So advice, guidance, support. We do workplace needs assessments. And one of the things we're most proud of is we do a massive amount of social and leisure activities for ASC people. So we provide groups and leisure activities, really, anything that individuals want to do that are really a safe space for friendships to grow and develop. And we've actually had a couple of weddings through our social and leisure activities. We offer training and we offer consultation as well on all things ASC. Next slide. So that's it for me. Any questions from anybody?
Hi, I'm looking at the chat. There's like 3 questions in the Q&A.
Okay.
Yeah, so I think the first one's from Anna that says, in all the cases with autism need treatment, or is it just like for person to person? Sorry, I'll just stop.
I think there's in some cases, I think we need to kind of stop. I'm going to be a little bit brutal, I guess. So one of the things, so autism sits under what we would term neurodiversity, which is at its heart differences in the way that individuals process information. So it sits alongside lots of other things: dyslexia, dyspraxia, ADHD, dyscalculia, all of those things. So it comes down to the treatment. It's not we try and avoid medicalizing a lot of these neurodiversities, because treatment kind of means that somebody's broken or there's something wrong with them. For many autistic people, they don't feel that they're broken and they don't feel that they want treatment, and they're perfectly fine. Thank you very much. So I think it really depends on the individual. It's more about supporting the individual to achieve their goals in life. So for somebody that might be, going out for a meal. We had one of our clients who basically is really anxious about going out, so hasn't left the house since March. So we're supporting him with getting out and about again. We have, and it's about the support that somebody means, you know, that enables them to live happy, fulfilling lives, and that tends to be on an individualized basis. Okay.
Yeah, and oh, yeah, I think Anna again, they've got another question saying, how will we know if a person have autism or not? I mean, from like, I mean, from the day of born. I'm guessing they're asking like, how do you know if someone's autistic?
It really depends. So autism is a spectrum. So if somebody is severely autistic, then it would mean that they would rapidly fail to reach developmental milestones. They would probably be nonverbal. They would have massive social and communication skills, and they would be picked up very, very early on. But at the other end of the spectrum, where you have higher functioning autism, which we used to call Asperger's or higher functioning autism, it could be that individuals would go through their whole life not knowing they're autistic. It's not unusual, for example, for parents of autistic children to recognize themselves in their children. And so it really massively varies, and that really varies depending on the severity of the way that the individual, the autism impacts on the individual. But it's a whole of life thing. So essentially, like other neurodiversities, you're born with it, you live with it, you die with it. And so it's always with you, it's always present. It's quite often whereabouts on the spectrum, how it will affect you, whether it's sort of severely, has a big impact or much less of an impact.
That's a great answer. And I've got two questions that are quite similar. One of them says like, how do we access I am and whereabouts is it in Manchester? And another one is, would it be possible for students to volunteer with I am?
We love having volunteers. And actually being volunteer with us is really cool, because a lot of the social and leisure activities that we do are properly cool. So, we go and our members tell us what they want to do. So it could be anything from playing crazy golf, through to going to Blackpool and riding hideous roller coasters, to simply going to the pub. We're always happy to have volunteers. Our office is in Stretford. And I think the address is on the last slide of my PowerPoint, which I'm quite happy for.
Yeah, I will share it. Don't worry.
So we're based in Stretford, but we cover all of Manchester. So some of the stuff we do at our premises in Stretford, but other stuff we do out and about in the community or at different venues. So, but our social nights are good. You need to come on one of those. They're pretty cool. They're a good laugh.
And we've got quite a couple of questions coming. So one of them says, at what point would a diagnosis be given? As some things could be considered as normal, part of life, example for like anxiety or depression. When are people diagnosed? Also, yeah, and they're also thanking you for the presentation.
Oh, that's really
Yeah,
kind. Thank
it's
you.
very nice.
Again, diagnosis, it would really quite often depend on the severity. So for very young children with severe autism, they'd be picked up pretty quickly. Many children are picked up in school because they don't get the social and communication challenges become more obvious, and those tend, unfortunately, to lead to behavior issues such as having meltdowns and outbursts. So quite often it's the behavior that is picked up in school, where that's what leads people to getting picked up and getting diagnosed. But equally, it's not unusual for individuals to be picked up at any part of their life. So that might be at college, it might be at university, it might be in work. So diagnosis can happen at any time.
Yeah, that's great. Thank you very much. And I think, is it all right if I share your PowerPoints later on to the attendees?
Yeah, please do.
Yeah, that's great. So I've got a couple of questions coming up. I think, would it be all right? Some of them you end up like typing in the answers.
Yeah, do you want me to type those in? Well,
Yes, please, because
because I'm
I'm
just
noticing
conscious
that we're
that
running out of time because we're
you're going to
all.
run out of time. Yeah, cool.
Thank you very much.
No worries. Well, thank you. I'll just type these in now while you're all going and having a break. But can I just say thank you for having me? I've loved, I can talk about this stuff till I'm blue in
Yeah.
the face. So it's an absolute honour to get to do it on on a Saturday evening. And I just hope you've found it all useful.
Honestly, I think I guess from the questions I can say from everyone else's and from mine, thank you so much for giving this presentation. It's given me a whole new perspective on like what it's like to be autistic. And I feel like it makes me more considerate and also more conscious.
Perfect. My pleasure. So I'm just going to stay on and I'll type these the answers to the questions in. So I'll hang around for a bit if that's okay.
Yeah.
Perfect.
I think at the chat there's two questions. One of them says, is it important that people with underdiagnosed high functioning ASC get diagnosed? And another one is, it's a quite lengthy one. I think it's a personal story you might enjoy.
Okay. So I'll just type these in while you're having a break, as long as it stays open for me.
Yeah.
Perfect. So thank you very much for inviting me, Saz.
Thank
Really
you very
enjoyed
much, Helen. It was a pleasure to have you. Yeah, so I think because we really went into the Q&A, I'll delay the next speech by like, I'll give you guys until 6:52. I'm being nice and considerate. And then after we'll have David Branford giving his lecture. Well, it's a talk, but that's again, it's also really interesting. And it's also quite interactive. All right, it's 6:52. If David's ready, anytime. Floor is all yours. Sorry, David, can you hear me?
I can.
All right, great. I was just worried for a second. I was like, oh, not tech issues again. Yeah.
Yeah, the computer did something funny and chucked me out, so I had to get back in again.
All right.
Okay, tell me when you want me to start.
Oh, I'm ready whenever you are.
Okay, hello everyone. I hope you're all enjoying the Saturday evening. So I'm Dave Bramford. I'm a retired mental health pharmacist, and I've spent most of my life working in this area. I thought I would just reassure some of you. What you will have heard from the previous speaker is a huge variety of mannerisms and behavior, which are all part of the autistic spectrum. And some of you will probably be looking at this thinking, oh my goodness, I've got that. And I've got that. And I was reflecting on the fact that I went into half a dozen shops this afternoon, and they all had the most horrific music going on in them of Santa Claus and riding jingle bells and stuff like that. And by the time I got to the sixth shop, I really thought, no, I can't tolerate this anymore. So don't worry, it's completely normal. And I don't have autism. So I think a lot of the behaviors that you will have seen there, as the previous speaker said, really are part of a spectrum. So let's look a little bit more then at how we might, what are the core features then? So if we go on to the next one. So we've already talked about it's lifelong, it's a developmental disability, and it affects how people communicate and interact with the world. 1 in 100 people are on the autistic spectrum. So most schools of pharmacy have about 100 students. So probably in your year, you've got someone who has many of the traits of autism and probably would be able to be diagnosed. And you may well actually have people within your group who you can think, oh my goodness, I'd never realized before that they have some of these traits. So there's 700,000 autistic adults and children in the UK. So that's come from the National Autistic Society. Okay, onward then. So it's a bit of a history and background then. Was if you had children who had behaviors that you didn't like in the past, you tended to beat them and make them behave. And so really, whether or not these would be regarded as problems really has been relatively recent. So many of you would see 1943 as a long time ago. But in terms of diagnosis and so on, that's relatively recent. So autism was first described by a chap called Leo Kanner in 1943. And then another chap called Asperger, he described something similar, which was called Asperger's syndrome. So the condition then became more widely known following the work of this lady called Lorna Wing. And she then developed some kind of a diagnostic approach. So we've seen a whole variety of behaviors. So it's really, how could you make a diagnosis of autistic? Right? So I think a number of you were asking. So it doesn't matter how bright you are, these core behaviors, which are the ones in what we call the Wing criteria, are the ones which people meet a diagnosis. So go on to the next slide then. Okay, so I'm sorry about the long words, but this is the way they are described. So qualitative impairment in reciprocal social interactions. So the way that people interact with you is quite different. Qualitative impairment in verbal and non-verbal communication and in imaginary activity, that I think has demonstrated with the previous speaker. And also a marked restrictive repertoire of activities and interests. And again, that was talked about before. So really people have very limited interest. So those are the three things you have to have in order to make a diagnosis. Now, that would be the Lorna Wing, but as our previous speaker said, the diagnosis of autism is changing all the time, and maybe the way it's looked at is changing also. Okay, on with the next slide. There's just a bit more detail. Probably we don't need to go into all of this. If you are having a copy of the slides, you'll be able to look at these. So in case of social impairment, then the person has difficulty with social cues, which has already been said. They have difficulty with empathy and emotional issues. They have problems with communication and language, and they have impairment of imagination and behaviors. So interests tend to be quite narrow. Okay, now some of those behaviors, you probably look at them, as I said already, and think, oh my crumbs, I've got some of them. But it's whether or not you have the core symptoms and it becomes a problem for you. Okay, onward. Okay, so we talked about the fact it's a spectrum, affects people in different ways. And now we're going to look at a video from the National Autistic Society, which discusses the various key problems and difficulties. So over to the video. Are you able to do that, Soz?
Yeah, just a second. I need to stop sharing and share again.
This is the high-tech moment.
Yeah.
All
right.
Autism is a lifelong disability which affects how people, like me, communicate and interact with the world. There are about 700,000 adults and children on the autism spectrum in the UK. And like everyone, each autistic person has their own strengths and challenges. But all of us have difficulties with communicating and interacting with other people. This could mean not speaking at all, needing longer to process information, or not understanding facial expressions. We also engage in repetitive behaviour, doing or thinking the same thing over and over. This is sometimes for fun, and sometimes to help deal with our anxiety. People on the autism spectrum can also find unexpected changes, however small, very distressing. And then there is sensory overload, where noise, smells, touch, and bright lights become very painful and overwhelming. All these challenges can make the world feel very scary and hard to understand, and sometimes send us into physical and emotional meltdowns or shutdowns. It is very important that autistic people get help from an early age. But life can become very difficult if children or adults don't get the right support or understanding. Autistic children are 3 times more likely to be excluded from school. Only 1 in 6 autistic people in the UK have a full-time job. And over a third of autistic adults have reported serious mental health problems. The National Autistic Society is the UK's leading charity for autistic people. Since 1962, we have been changing society's attitudes and transforming individuals' lives. We want to create a society that works for autistic adults and children, and with your help, we can.
Okay.
Yeah.
There we are. So there's the key problems and difficulties, which I think came out in that social communication, repetitive restrictive behaviors, oversensitivity to light, sound, taste, highly focused interest, extreme anxiety, meltdown, shutdown. Okay, onward. Now, our next speaker is going to talk a little bit about the autistic spectrum in people with learning disabilities. But there's been quite a lot of work looking at the relationship between autism and intellectual disabilities or learning disabilities. And you'll see from this slide that the presentation of autism can be different depending on your IQ level or your intelligence. So people with a high IQ may present quite differently from people with the severe learning disabilities. And Daniela, our next speaker, is going to talk a little bit more about learning disability and the relationship with autism. Okay, onward. Okay, so this is the point at which I'm going to invite three of Soz's friends. They might not be their friends for much longer after this, but we're going to ask them a number of questions about why might medicines and pharmacy present a problem to people with autism. So have you got your first colleague lined up, Soz?
Yeah, they're all there in the panelists.
Okay, so the first one is the first student's going to look at the question of whether the medicines themselves and what they look like might present a bit of a difficulty for people with autism. So over to, what's your name?
Hi. Hi, my name's Clavel.
Okay, right, go on, off you go.
Right. So about the medication, and like my thoughts on it is the change of routine, for example, the regimen of the medicine or like the look of medicine can be like very distressing for autistic people and makes them feel very anxious. Like it could like because it is like a change of events, and autistic people might be like very attached to objects, for example, like figurines or toys or model cars, or just something more unusual, like anything. It could be stones or shoes, just anything that, you know, changes might distresses them. So if they're gonna change the medication, then, or the look of the medication, that might really distress them for the first bullet point. And so for coming into the pharmacy and communicating with the pharmacist, I feel like they might find this very distressing as well. Like coming into the pharmacist, like on the way to the pharmacy, like as the last speaker said, that noises and like lights can be very distressing for them. It might be very challenging for them to even come into a pharmacy and talk to a pharmacist. Yeah, that's my thoughts.
Okay, thank you very much for that. Now you will know that there's a lot of discussion going on at the moment that the Royal Pharmaceutical Society is trying to get a situation where pharmacists can change medicines without consulting the doctor, or that they can change brands, or if there's a shortage of a particular brand, they can go for another one. And obviously, if a person with the autistic spectrum, person with autism has a particular expectation of a color or a taste or an appearance, they might not be very happy about the fact that the medicine doesn't look quite the same as it was before, and might get really quite agitated about all of that. In my career, we always had people who insisted that they had a particular brand, and that the particular brand that they took, any other brand was never as good. and they were very attached to the fact that they were blue ones, and if you gave them a green one, they wouldn't want it and they would spit it out and so on. So the medicines and what they look like may have quite a significance to the person. Thank you very much. As you've got a second colleague now, what about coming into a pharmacy then?
Yeah.
Hi, my name is Insu, and my thoughts on people with autism having problems with coming to the pharmacy might be, well, first of all, they'd have to travel to the pharmacy. If they live quite far, then they'd have to take public transport or something like that, and that could just be like a really distressing environment itself, because I mean they'll be like surrounded with other people and there might be too many people on the bus, like lots of noise, people talking, things like that. And also just the fact that they'd have to communicate with like a new person that they've never seen before. I think that could be something that could give them anxiety. And even, you know, things like different temperature, like different noise, and there's a whole new environment.
Yeah.
So they'd have to kind of adjust themselves in that. And it could, I think it could even like cause physical pain for them. Yeah, someone mentioned
Very
on the
good.
fact that public transport being not on time could distress them, and I think that's quite true. Like just little things like that, we just kind of shut out.
Yeah.
That
So
they would
you
be
might
so
say to
sensitive.
them, yes, your medicine is going to be ready in 20 minutes time, and they come back in 20 minutes and it's not ready. And so that might be quite distressing for them. Yeah.
Yeah, exactly.
Okay, thank you very much. Actually, I went into a large chain community pharmacy this afternoon, and I found the whole experience quite unpleasant, really, because they had jingle bells going on very loud, and it was all very bright lights, and it was very crowded, actually, and I had to have my mask on and all the rest of it. So I thought, well, actually, coming into this pharmacy is pretty unpleasant for a person without autism. So probably coming in with autism wouldn't be very good. Okay, thank you very much. What about number 3 then, communicating with the pharmacist?
Yeah, that would be Amin.
Hello, I'm Amin. About the last part, I think the pharmacist should actually ask the patient that what specific problem they've got, so like what is annoying for them, and I recommend the pharmacist use the consultation rooms to somehow adjust the environment for the autistic patients so they can feel more convenience in the pharmacy. And in terms of communication, I think the pharmacist should be really clear about the terms they're using, the words, the choice of words matters so much, and they should avoid jargons and like unrelated topics, anything, even things that can be confusing for the patient. And they should make sure that they've understood what they told them, and maybe if they ask the patient to like repeat what they've caught from the consultations to ensure that they understood it properly. And yeah, basically.
Very good. Yeah, thank you very much. I hope people are putting more ideas on the chat, and we'll perhaps look at them when we get to the end of the presentation.
I guess.
Okay, let's carry on then. So the question is really, when might people with autism be prescribed psychotropic drugs? Well, let me firstly say that there is no drug for autism. You cannot give a drug for autism, but clearly the person with autism may have all sorts of other difficulties and problems, and they may really become too much for the person, and there may be a pressure on people to prescribe drugs that will calm them down. Now, the latest NICE guidelines on autism said that medication has a limited role to play in the treatment of spectrum disorders and should only really be considered if there's a really major problem. So if it's part of a plan, the environment, other strategies such as psychological strategies are proved insufficient, and that the impact on the person's functioning and those around them is very severe. So really, unless the person has got a secondary problem, which is really causing them difficulty, we should not be seeing the prescribing of psychotropic drugs. However, if we go on to the next slide, there's really a lot of concern at the moment that there's a move towards treating people who have a wide variety of difficulties with psychotropic drugs, either tranquilizers or sedatives or other kind of drugs. So there's been, in particular in America, really we've seen a very large scale prescribing of psychotropic drugs for children, and this is really quite a big change. So a chap called Dove, he looked at the patterns of psychotropic medication prescribing for autism spectrum disorder, ASD. He looked at 47 studies, which included over 300,000 people, and he found there was a huge variation in the prescribing. In the various studies, they range from 2.7% of people on psychotropic medicines right up to 80%, with a median of about 41% for children and 61% for adults, and lots of psychotropic polypharmacy. So when you compare that to the previous slide, which said that really psychotropic drugs hadn't got much of a place in the autism, you'll see that there's really a large scale prescribing for them. Antipsychotic drugs are the most frequently prescribed, followed by drugs for attention deficit hyperactivity disorder and antidepressants. So their conclusion was that despite the lack of pharmacological treatment options, the prevalence of psychotropic drug prescribing was considerable. And so if we go on to the next slide, that's really, I think Danielle's going to talk a little bit about STOMP as well. Really led to a major campaign which has been going on over the last few years, which I've been very involved with, which is to stop the over-medication of people with learning disability, autism, or both. And there's a whole variety of, there's a website there, and there's a whole variety of material all about medication and learning disabilities. Go on to the next slide, please. Okay, there's more of the material that's available. So that over the last 2 or 3 years, we've been developing lots and lots of material to help people about their over-medication. And obviously, people get prescribed medicines and don't always understand why they're on them. And this campaign really is focused on trying to move people away from being prescribed medicines and onto other treatments. So let's go on a bit more. Okay, so this, Many of you will know that we had the publication a couple of years ago of the NHS long-term plan. Children and children disorders feature much more strongly in this long-term plan than any previous plan we have had before. In the past, there's been really quite a denial that children have problems, and really this is beginning to change very dramatically. So in the long-term plan, the STOMP program features psychotropic medicines are more likely to be inappropriate prescribed for people with learning disability or autism. And the plan is that the program, which I've been involved with, called STOMP, stopping treatment with inappropriate medication, and STAMP, which is the children's equivalent, should expand, and more of that. Now, many of you might be quite surprised to find a pharmacist heavily involved in trying to get people taken off medicines, when obviously pharmacy is all about medicines, but this is really something that you should be increasingly becoming aware of, is that sometimes people end up on all kinds of medicines for all kinds of strange reasons. Often it's following on from a crisis, and people can then just end up left on medicine for years and years and years when there's really no requirement for it and they should have come off. So the STOMP program is part of a big national program called de-prescribing, and under the long-term plan there is the proposal to set up de-prescribing clinics around the country as well, to help people come off medicines that they maybe don't need. So there we are, that's a long-term plan. Onwards, next slide. There's STOMP and STAMP. STOMP aims to stop the overuse of psychotropic drugs for people with learning disability, autism, or both. And STAMP is about making sure that children only get the necessary medicines that they need and not others. So they're all about helping children and young people stay well and have a good quality of life. We want people's medicines to be regularly reviewed, and if they don't require the medicines, to come off them. Okay, next one. There we are. Okay, how are we doing time-wise?
We're right on time. So if anyone has any
questions. Wonderful. Okay, so have we got some chat, or let's have a look?
Yeah, someone says, is there a link between OCD and autism?
Okay. Right. Obsessive compulsive disorder has the word compulsion in it, and the major presentation of obsessive compulsive disorder is that people are driven to do a particular thing. So, for example, we find obsessive traits are very common in pharmacists. Many pharmacists have compulsive traits, and as our previous speaker said, sometimes these traits are incredibly helpful. Pharmacists are very good at detail and being very thorough, and so it's understandable that some of these traits sound very familiar, because they come into the autistic spectrum and they also come into obsessive compulsive behaviors. So we find that obsessive compulsive behaviors are very common in pharmacists, and they're quite helpful. So obsessive OCD is a diagnosis. To give you an example, if you couldn't stop, so at night, for example, even though I know I've locked the back door, I always go and check it before I go to sleep. Now, people would say, well, you know, you didn't need to do that because you knew the back door was locked. And so I'll say, yes, but I wouldn't be able to sleep if I hadn't gone and checked that the back door was locked. Okay, so that you would say was kind of an obsessive behavior. Now, obviously, if if I then repeatedly I had to go and check the back door 6 times before I would feel comfortable to go to bed, and then I would still wake up in the night and still go and check the back door, then that has become a problem, and I'm being driven to obsessively do those behaviors. Does that sound different from autism?
Yeah, I think that explained it quite well enough. And I think there's
Yeah, but you can see that there is quite an overlap. And one of the problems we have with autism at the moment is that all of us have various traits. All of us have various behaviors, and you can look at all the behaviors that you see in autism. And as I said earlier on, many of you would have looked at them and thought, "Oh my gosh, I do that, and I do this, and I do that." And as was said before, some of these behaviors are actually incredibly helpful and useful. But it's when the behaviors become interfering with the person's life and make them unable to live a happy and successful life, it then becomes a problem.
Yeah, that's great answer. I mean, I understood more about that. And I know there's a bunch of other questions in the Q&A box. So one of them says, are anxiolytics often used and required for severe anxiety from autism?
Well, the drug of choice at the moment for the NICE guidelines on anxiety is the selective serotonin reuptake inhibitors, or the antidepressants. So drugs like fluoxetine and so on. And we are seeing an enormous escalation in the prescribing of these drugs across the whole of the population. What's quite difficult at the moment is to work out whether we are seeing an even more increasing use amongst people with autism and learning disabilities. We think we probably are. So anyone who looks at the data will see that the use of selective serotonin reuptake inhibitors in this population is massively growing. There was a theory a number of years ago that autism was improved by using antidepressants. I think almost all the evidence has suggested that that isn't the case. So we're still seeing a very large scale use of them. The other group of drugs which we're seeing increased use of as well is the benzodiazepines, lorazepam and diazepam, Valium. Often what's happening here is that the person is prescribed them in an emergency or in a meltdown, and then people don't take them off afterwards because they find that they were helpful, and they should have only really been used for a short period of time. So we are also seeing an increased use in them as well. We're seeing an increased use of almost every psychotropic drug, and again ADHD medications as well.
Yeah, that was a great answer. Thank you. I'm a bit conscious about time because I know this is during the
Okay,
break.
I'll
So
be quiet.
yeah, we've
Daniela,
still got a bunch of questions. So if you could still answer those via chat, just
okay.
in case anyone wants to grab a cup of tea, anything. But thank you very much, David. It was very informative, and it was very interesting how it also applied a bit of from what like Helen's talk earlier. So it also gave a bit of a pharmacy perspective, and it was very wonderful. And thank you very much for giving your time to give us this talk.
So I seem to have disappeared.
Oh yeah, sorry. I was just wanted to let you know that there's still some people that have asked questions in the Q&A box. So if you could
Okay.
answer the questions, that would be great. Because I know I'm a bit just conscious of time, so we might not be able to like discuss
Yeah,
it.
so we'll have them at the end, shall we?
We can have them in the end, or you can also type it in, whatever you would like.
Okay. Yeah. Okay. We'll see how we get on. Yeah. Okay. So I'll be quiet now.
All right. It's 7:30, so the third speaker is Danielle Adams. She is a mental health pharmacist and she specializes in learning disabilities, and she has another amazing talk coming up. Let me just try and upload. Technology. Yeah, whenever you're ready, Danielle.
Can you hear me, Soz?
Yeah, I can hear you.
Yeah. Okay. Yes. Okay. Well, I think I should be fine. I'm just checking my computer had enough battery power, so I think we should be all right. So thank you very, very much for inviting me, Soz. It's a privilege to speak at this evening's event. And I've got a hard acts to follow with the presentations from Helen and Dave. They were very informative this evening. I've certainly enjoyed listening to them. So I'm an independent specialist mental health pharmacist, and I have a special interest in medicines optimisation in people with learning disability. And I'm also a PhD student at the University of Warwick. My PhD project is looking at the effects of deprescribing psychotropic medicines in people with learning disability, which links into what Dave was saying about the STOMP programme. And I'm also an expert by experience in neurodevelopmental conditions. So yes, next slide, thank you. So I'm conscious that I don't want to repeat what the other two speakers have been speaking about. So I'm just going to talk a little bit about neurodevelopmental conditions. I'm going to talk a little bit more about learning disabilities and how this all fits in with medicines optimization, and also give a couple of pointers about how we can make our practice more inclusive. So next slide, please. This isn't a very good slide. I have to apologise. Actually, I took this. I've set up recently on Twitter MediSafety, which is a Twitter group to share good practice. It's a pharmacy-led network looking into sharing good practice in medicines optimisation in neurodevelopmental conditions. But I've just really put this up there because I know Helen touched on this, and also Dave. But there's a lot of comorbidities, which means that lots of people with autism also have ADHD, dyslexia, dyspraxia. And something that's quite important as well to think about as well, like Helen was talking about autism in girls, it's often undiagnosed. ADHD is the same as well. And when I first started working in the field of mental health, and that was back in 2012, there were still some clinicians that thought that ADHD was something that was just a condition of naughty schoolboys that disappeared, when they left school. That isn't the case. As with all these neurodevelopmental conditions, they are lifelong, but people learn to, we get strategies to overcome them. And I'm sure as well that many of you sitting here listening to the webinar, many of us may have dyslexia, dyspraxia, autism or ADHD. And in the school setting, people with dyslexia and dyspraxia may have slower processing speeds, may be given extra time in examinations, and we're quite familiar with that. Now, somebody put in the chat box about how do we know if somebody has autism, and that's what's actually quite complicated here, because I say in the school setting, I think your teachers maybe tend to know about these things, but once we leave the education world of education, it can be quite complicated actually, and that's why I want to get you thinking about your practice as healthcare professionals and how you can make your practice more inclusive. So next slide, please. So what I wanted to focus on in my talk is a little bit about intellectual disability. So intellectual disability, or intellectual disabilities, sometimes you see it written as the plural, is actually the same thing as learning disability. But in the United Kingdom, NHS social care and educational services use the word learning disabilities, whereas in other countries, researchers use the word intellectual disabilities. So, for example, in my PhD, I'm using the word intellectual disability because so when I publish papers, it will have a global appeal and understanding. However, in the United Kingdom, when we're talking about services, we're talking about learning disabilities. So these things do get confusing, but I just wanted to clarify that it is actually the same thing. Now, MENCAP, the national charity, I'm sure many of you have heard of MENCAP, they define learning disabilities as a reduced intellectual ability and difficulty with everyday activities. And this affects someone for their whole life. This is important because it's not the same as dementia, which is something that comes on later on in life. And people with learning disability do tend to take longer to learn and may need support to develop new skills, understand complicated information, and interact with other people. Next slide, please. So around 4 in 10 autistic people have a learning disability, and that's why I thought we ought to discuss that this evening as well. And that learning disability, a bit like autism, is a continuum, and it ranges from mild, moderate, severe, and profound. So, you know, people with, it's important. So you may not necessarily, again, know someone has a learning disability if it is mild. And all these disabilities, and I think Helen did touch on this about being hidden disabilities, that sometimes you don't always know that someone has a mild learning disability, and they won't necessarily have access to specialist intellectual or learning disability services either. They may be in very much general services, health services. Next slide, please. So health inequalities. Now, this is really important, actually, because people with learning disabilities have worse health than people without learning disabilities, and they're more likely to have several health conditions. The poor quality healthcare can cause health inequalities and even avoidable premature deaths. Worse physical and mental health than people without learning disabilities. And on average, women with learning disabilities die 18 years younger than women in the general population. And for men, it's 14 years earlier. So as pharmacy professionals, and I know there may be other people on this webinar that don't work in pharmacy, but there may be other health-related professions, is that we can all play our part in addressing these health inequalities. Next slide, please. So what are learning difficulties? Now, this is all getting confusing, isn't it, with all the different types of definitions. And actually, also the language we use. So as Helen pointed out, we used to use the terminology autistic spectrum disorder. We tend to use the word autistic spectrum condition. And when we talk about neurodiversity, we tend to talk about neurodevelopmental conditions. So sometimes we hear the word learning difficulties. Now, technically, a learning difficulty is something like a dyslexia or dyspraxia or dyscalculia. But actually, sometimes it's confused. And sometimes I was doing some e-learning the other day with Health Education England, and they'd got all confused on this module between learning difficulties and learning disabilities. So sometimes it all does get confused, but that's actually what we mean by learning difficulties. And that's the terminology also in United Kingdom. It's not the same in other countries. So I know that does sound confusing, but the other thing that may also be a little confusing is sometimes when people, when parents have a child with some which is suspected learning disability, the learning disability register is not, people don't go on the register for having a learning disability until they're age 14. And sometimes parents don't like to use the word, say their child's got a learning disability, because they find it quite hard to use that language, disability. So you might find some parents talk about their child having a learning difficulty where actually it is a learning disability. So that's just to make that point there. I mean, it is probably not that relevant to you, but you may get confused. Is there any difference? Anyway, that's the answer to that. So we move on to the next slide, please. And the next slide's about dyspraxia. That's fine. You want to move on. Now, this is really, really important. Really, really important. And if you don't remember anything else from my talk this evening, please, if you could actually think about this for a minute. And why I say it's so important is that when I was working at Mental Health Trust, I used to have to investigate medicines incidents or medicines errors. And many of these errors occurred in primary care, GPs, pharmacists, and sometimes these errors were to do with a lack of understanding of the context and in learning disability and where people with learning disability live. So many years ago, people with a learning disability and autism, some of them lived in what we could best describe as an institution. Now, those institutions now, many of them have been closed down in these long stay hospitals. And now people with learning disability may live with relatives, they may live on their own in their own home, they may have a flat share, they may have support, they may not have a support. But why this is so important is that what I've seen in my clinical practice, that sometimes there was issues with medicines and the GP or the pharmacy professional would say, oh, it's fine, they'll have a carer to sort it out. Well, that's not always the case, because not everybody with a learning disability and autism has someone to sort their medicines out. So you can't. So it's very important to realise that not everybody lives also in a care home. Some people have this idea that everybody with a, they don't. They may live in what's known as a setup called supported living. You may want to consider, how does that differ from residential care? So next slide. So residential care, and the difference between that and supported living is that in effect the local authority has to pay all the money to support someone who's going to be living in a residential care home. Whereas if they live in their own home and they have supported living, they pay for the support, but their actual rent that they pay, they'll claim that back from housing benefit, which comes from central government. So that means that lots of local authorities don't really want to support people to live in residential care because it costs them a lot more money. But actually, what's also happening is we're seeing that lots of services are commissioned for care homes, but they're not commissioned for supported living. Now, I hope I'm not really confusing you, but what I'm trying to explain is that just because someone doesn't live in a care home does not mean they have intellectual disability. It doesn't mean that they don't have particular communication needs. It's just the way the setup is. I know I'm probably making things sound a bit complicated here, but it's very important to look at the person. It's very important to think of their needs, not the fact that whether they live in a care home or whether they live in their own home. It's that level of support they require. Now, the other thing it's very important to think about it, that many years ago, when we did have these old-fashioned institutions, and none of us want to go back to that, but what used to happen is there may be a local GP practice or the local pharmacy would provide services to those institutions, and therefore they developed expertise in the field of learning disability and autism. But since those have been removed, it could be that a pharmacy may only provide services for 1 or 2 people with a learning disability and autism, and the same with the GP practice, because people are not living just in one concentrated area. So what's happened is there's actually been a lack of experience and lack of understanding in many of the primary care services how best to support people with autism and learning disability. The other thing to think about is the level of support. Again, you can't just assume because someone has a learning disability or they have autism that they have a certain level of support. You have to be sure, if you want to know about that, then you need to find that out. And I say that's one of the areas where I found that there has been medicines errors because healthcare professionals have assumed there's a level of the support that isn't actually there. So next slide, please. So let's go on to medicines optimisation, and this slide comes courtesy of NHS England. Now, some of you may be first year students and therefore you may not be familiar with medicines optimisation. I'm presuming by 4th year you have covered medicines optimisation. I'm not sure how it works these days. So optimising medicine. So we have to think very much here about a patient-centred approach, and we need to aim to understand the patient's experience. And this is really, really important, especially when we're trying to be inclusive of and make our services accessible to people with autism and learning disability. So somebody asked a question, how do we know if someone has autism, or and that's a really important question to ask. So what I was thinking about was that if you take the scenario of a school teacher, if a school teacher puts up the homework on the board at the beginning of the lesson, or perhaps they put it on, they may email it to the students are very clear what they have to do for their homework for the next lesson. However, some teachers, what they may do, they may, at the end of the lesson, the bell goes, everyone's packing up all their bags, and then they announce what the homework is. So if you have autism or dyspraxia, where you have problems processing, you have a slow processing speed, and with the autism, the noise perhaps of everyone packing up their bags, you may miss that last bit about the homework. And then that might be that the person might get very stressed, they might get anxious, they might get, told off they haven't done their homework. Whereas if all the teacher had done was given them advance notice at the beginning of the lesson or emailed them, they would have caused far less stress. So maybe it might have only helped 2 or 3 people in the class, but look how much more accessible the lesson is. So I think we need to think about this in clinical practice. We need to make adjustments that actually work for everybody, because if they work for everybody, then it wouldn't matter so much if you weren't sure if somebody was autistic or not. It means that everyone can access what you're saying. And as a pharmacist, we are well known pharmacy professionals because we're experts in medicines. We often want to tell everyone about everything we know about medicines. And sometimes we have to be a little selective. We have to think, what is important to that person? What do they need to know? What's important to them? And I think that's really, really important as well. That's another sort of take-home message to think about, not just telling them what you want to tell them, but think, what do they need to, what do they want to know? Especially if we think about people with a short attention span, and maybe people with ADHD type conditions, that they may find it hard to focus, or the sensory overload that can affect concentration. Next slide, please. So if we're thinking about understanding the patient's experience, I say let's have a sort of think about people with autism and other neurodevelopmental conditions. So the communication and patient consultations. Now, I think Helen and Dave has been talking about that, and communication is really important, and also not to use certain types of, when you speak, you don't want to make sort of type of jokes, or they may not understand what you're saying. But I think that's important when we're talking to anybody, actually. I think we need to be very clear. And Helen made the point about, what does it mean take your medicine after food or before food? Well, it's interesting, actually, because say something like take a medicine an hour before food, something like flucloxacillin, antibiotics. Now, that's actually quite hard. 4 times a day, an hour before food, is actually not easy. So I've come across people that have just stopped taking the medicine because they've forgotten and they've eaten something and they think something terrible is going to happen. Well, I think it is a little bit more, I think rather than just relying on the label, we do need to explain to patients what we mean by that and what's important. So actually, it's not just, if we change our practice or think about optimizing our practice, it won't just help people who are autistic, it will actually help everybody to be very, very clear about what we would like to happen with their medicines. Another thing we need to think about is the availability of accessible information. That's really important, because we have to also think about literary impairments. Can everybody read? I mean, we're assuming everybody can read, but that's something we're just making an assumption there. We need to think about the environment. I think we've touched on this today very much about the sensory overload, and also it's offering people choices. You may assume that somebody may want to come to the pharmacy or the other clinic where you're working, maybe it's a quiet time, but actually that might not suit them. They may want to come in their lunch break, they may be working. So it's about asking them what's right for them. And then we're going to also, I'm going to come on to this in a minute about shared decision making, and also how patients know how long to continue taking their medicine. This point is really important. Sometimes we think about people not adhering to their medicines program, or they stop taking their medicines. Now, for some people, especially young people, it may be that the only medicine they've ever taken is some antibiotics for maybe 5 days. And so they may think if they're given a supply, their initial supply that might have been from the hospital, it might have been for a week, they may think that's all they need to take. If no one's told them they have to carry on taking their medicines, well, then are they going to know that they are going to be taking them, like they have to get repeat prescriptions? So some of this sort of general information is so important. And again, many of you listening to the presentation today, just think a lot of this is actually common sense. It's actually, when you actually think about it, how would people know they're supposed to be carrying on taking it if no one's actually told them? So I think it's just thinking about this, and also thinking about things as from trying to put your trying to think from the patient's perspective. So can we move on to the next slide? Now, a very important part of the NHS long-term plan is shared decision making. And shared decision making ensures that people are supported to be as involved in the decision making process as they would wish. Now, this is quite different from many years ago. You used to think about going to the doctor would tell you what to do, and you just did what they told you. But these days, it's very different. There's a partnership here. And working together, patients and healthcare professionals choose a treatment plan based on the clinical evidence and the patient's informed preferences. Because of course, we're all experts, but we're experts in different ways. We don't know as healthcare professionals what the preference may be, the personal circumstances, their goals, their values, their beliefs. Take something, for example, you say you've done something to your ankle, you've had a slight ankle injury. There's lots of different ways of treating that. You could be putting ice on it. You could be going to have some physiotherapy. You could be doing some exercises. You could decide you want to take painkillers. Everyone's different how they want to approach it. So it's really important that as healthcare professionals, we don't impose treatment options on people without discussing it with them. Now, sometimes there's very little choice, isn't there? I mean, say if you went to the GP and you had a streptococcal throat infection, sort of penicillin, there's not really much other choice. So but in other areas, say that's the example of a problem with your ankle, something that you've it could be strained a ligament. It could be, especially in mental health, whether you are thinking about having psychological therapies or medicines. There are lots of different treatment options in those fields. And it's really important that we're all given good quality, easy to understand information so that we can make these important decisions about our health. And that's important when you are speaking to people with autism, that they are given the information, because people can't make a decision about their health if you've not given them the information so that they can make that decision. And you can't assume that people with a learning disability can't contribute to the decision-making process. And regarding the legal side of it, informed consent, under the Mental Capacity Act, everyone is assumed to have capacity unless you can prove so otherwise. So it doesn't mean that somebody with autism and learning disabilities, it may be that they can provide informed consent. So you mustn't make that automatic judgment in that way. Next slide, please. Now, we've talked very much about the environment already. The ability to focus and concentrate on the consultation. I was thinking about this and I thought, well, it may be that you might be in a position to sort of, you may speak to a patient and you may decide with them that they may come back and see you in a few weeks' time to tell you how they're getting on. And that might mean for them, it might mean that, if they're feeling a little bit anxious on that day. And also remember, people have to sometimes take on board, they might have a new diagnosis, so they're already thinking about a lot of information there. And also think about other sensory issues. I once worked in a pharmacy, in a hospital pharmacy. It was next to a hospital canteen. And at lunchtime, it was a really strong smell of food. Again, that could put somebody off, concentrating, especially someone with autism. So it's things like that is really important. Next slide, please. Oh, I think we just went past one. I don't know if one just went, there was something, I think. This one, that's fine. So changes to routine. We've touched on this already. We've talked about the changes in prescribing or deprescribing. It's the opposite really of prescribing. It's when it's a planned discontinuation of medicines. And these changes to routine can cause anxiety and it can be very stressful. There's also an issue as well, is that, and this is something I've seen many times, is that many of you probably come across these Dosset boxes that people have sometimes, well, they're meant to be for the benefit of the patient to get them used to independently taking their medicines, but more and more you seem to see them often in supported living, so to help carers. That's not really what they're intended for, but that does tend to happen. But with Dosset boxes, of course, they take longer to dispense. So what happens is often the prescriptions are sent to the pharmacy sort of well in advance. But it could be in the time that they're taken to the pharmacy, the patient may have actually had their medicines changed. They might have gone to they might have gone to an appointment at the hospital. And as a pharmacist, you might not know that. So you have to be quite careful that you're kept in the loop. Now, that's easier said than done, because what you don't want to find is that you're giving out medicines to people that actually the medicine's been changed. So I think it's really important is to establish a good communication with your patient. And so they understand perhaps the importance of communicating with you, that if there has been a dose change by the prescriber, that they tell you about it, because otherwise you wouldn't really, you wouldn't know. And I think there's lots of, when I'm talking about good medicines practice to sometimes to patients or carers, I talk about making sure there's lots of information they need to know. And some of the information is things like we need to tell patients how long they're going to need to take their medicines, which I touched on before, but also how long it's going to take before it starts working, because sometimes people give up taking their medicines thinking it doesn't work. So an example would be actually obsessive compulsive disorder, which we did just discuss before. And obsessive compulsive disorder, one of the major issues as well, differences between that and autism, is that it's a treatable mental health condition. So it's really important actually that we think about in OCD that sometimes it can take up to 3 months to get the full effect of the antidepressant that's used to treat it, whereas if it was for depression, it would start within a couple of weeks, you'd start to see an improvement. So if a treatment's could take up to 3 months, we need to make sure that the patient understands that, so they're well equipped. They understand how to get more prescriptions. They understand maybe side effects, how to manage those side effects, and what to do about them, and what to expect from the medication. Next slide, please. Now, many people with learning disabilities and autism, especially at the severe end, often have lots of other physical health conditions that might involve swallowing. So sometimes what can happen is it may be that the patient's not going to be able to swallow the medicine that's been prescribed, and it may be that we need to think about alternatives, and we have to think about swallowing difficulties. We need to make sure as well the patient understands how to take the medicine. And is it going to be safe? So one example, when I first worked in this field, we had a patient on an inpatient unit that was taking a bisphosphonate. This is a medicine that's taken once a week, and it's for it's usually for people with osteoporosis. But this particular person had a very unusual condition, and he was under a specialist centre in London. And he had a learning disability, and he'd come into hospital and his medicines had all been in a muddle. And I was very concerned that when he was discharged, this particular medicine, the bisphosphonate, there's lots of instructions. I don't know if some of you know about this. You have to make sure you sit up straight when you take it. If it gets stuck in the throat, it's very dangerous. And you have to take it an hour. You can't take any other medicines within an hour of taking it. So there's lots of restrictions about how you have to take this medicine. And I was reassured by the nurses on the ward, that they were going to arrange carers to give him his medicines. But what I did explain to them, I said, because you have to give it an hour apart from the other medicines, you're not going to have a carer coming in an hour and then an hour later. It's just not going to happen in practice. Also, because he'd been having it for several years, the evidence for over 5 years, it was not there. So we managed to get to speak to the consultants at the specialist centre, and they said actually no, he could stop it. Now he could stop this medicine, and it was actually discontinued. So it's very important that not only do we think how we're going to get this patient to take the medicine in a safe way, we have to also think, do they actually still need it? Because this particular medication is very toxic if taken inappropriately. So it's really important that we can go through lots of effort to speak to someone about a safe way of taking medicine. But if it's really not enough, if there's more risk than benefit, well, then one has to think, do they need to be taking it at all? And also we have to think about storage and making sure that people don't have, some people might think all the medicine needs to be kept in the fridge, or where, you know, so sometimes these are sort of, you might think that's usual, but we also, as I said before, some people have never taken medicines before, and they suddenly find they're having to take medicine. They're not used to it, and they actually don't have much idea. And this doesn't necessarily relate just to people with learning disability. It could be anyone who's just not familiar with taking medicines. Next slide. So I just want you to take a moment to reflect, and I think Dave's done a bit of this already today. What's important to you when making decisions about which medicine to take, and what's important to you when making decisions about stopping a medicine you've been taking for some time. So if you think of the sort of things you would be concerned about, then they're the sorts of things you may want to consider in your practice when you're speaking to people with autism and with learning disability, to think about all the things that are really important to you. And in fact, one of the things that I think is really important is that people are empowered to take control of all the medicines they're on, and in such a way that I think it's important that people keep a record, an up-to-date record, that is either on their mobile phone, or it may be written on a piece of paper maybe in their wallet. Because of course, if you go to the dentist, they could prescribe some medication for you, especially things like antibiotics, perhaps if you've got an abscess, and they could interact with some other medicines you're on. So it's really important to make sure that people who are on medicines, that they, and also things like allergies as well. The number of times, you speak to someone and they say to you, they say, oh, I'm allergic to a medicine, and they say, oh, I can't remember what it is, it's on my GP's notes. Well, that's not great if it's out of hours. So although I know a lot of NHS systems are now trying to link up, I think it's really important that people do take control and take back, that they know what medicines they're taking. And it's really important, just as important for people with learning disability and autism as anyone else. And that's how we reduce the number of errors as well. And it's also important at this point as well to think about over-the-counter medicines they might be taking as well regularly. Next slide, please. So key take-home messages from my talk today is that I think the way forward with this is to aim for inclusive professional practice, so that we therefore don't miss out on supporting people with their medicines where it's not, maybe we don't necessarily know that they have autism. So if we're as inclusive as possible, that way, hopefully, that won't be so much of a problem. But we also have to be person-centered, because everyone with autism is different to another person with autism. So it's too easy to say, oh, it's fine, I know somebody with autism, that person will be the same. We're not talking about a condition like asthma or something like this. It's very different. This is how people think. It's very different. Find out what's important to the patient. What do they want? Think about patient safety. Now, this is a really important take-home message. Don't leave it for someone else to think about. Like, assume there is some sort of care manager that is going to sort out all the medicines problems. A pharmacist, pharmacy professional, think about your medicines, think about the patient. And if something doesn't quite add up, like, you suddenly notice that something's been left off a prescription, don't think, oh, it's probably on purpose, they probably don't need it anymore. Or you might find that, oh, they're coming less frequently for the medicines, they're not taking it. If you're not sure, ask. And just to remember that pharmacy professionals and other healthcare professionals can make a significant contribution to addressing health inequalities, and by optimizing medicines that can make a big difference to the health and well-being of people with autism and learning disabilities. Next slide, and I think it's probably the end. Yeah. So if you wanted a bit more information, the MindEd platform, and that's free access there, and that's supported by Health Education England's got this useful educational resource. And there's also MediSafety on Twitter. And that's it for the moment. I have put my email address up there. So if any of you think of something else you'd like to ask me, please feel free to email me. That's no problem. And thank you very much for listening.
Yeah, thank you very much, Danielle. I think your talk was really nice. It's very patient-centered. It's a lot of the stuff that we as like pharmacy students, they're really like, I think they really like highlight on, they're really highlighting on patient-centered care. And I feel like, yeah, you really wrapped up also like David's and Helen's speech all together into like linking them all together is really nice. Thank you very much.
You're welcome. Is there anyone wants to ask?
Yeah, I think there's a bunch of questions. Sorry, let me see if anyone has questions.
I imagine a lot of the questions have already been asked, actually, because there's lots of questions, wasn't there, from Helen and Dave? Yeah, I think my message is about being, say, inclusive practice, a bit like sort of thinking about, say, the school teacher scenario, thinking about and being person-centered.
Yeah, but I think that's quite important too, actually, to be honest, because I know for us students, we've got OSCEs, and I think a lot of the stuff that you highlighted on, especially stuff like ensuring that this patient can swallow, because I know, like, you know, that's not something that we really think of, because you're like, oh, everyone can just swallow the pills. Why is there a problem in that, you know? And I feel like it's stuff like that that you actually like got us to consider.
There's also, I mean, I know of a case as well, someone's son who's got a severe learning disability, and I mean, they left the hospital where we're given a tablet cutter with these tablets, and the tablet cutter didn't work properly. The whole thing was really difficult. And then in the end, they were given a liquid, but perhaps a conversation would have been quite handy at the beginning. You know, if they had the conversation at the beginning, they wouldn't have gone through all the problems. It's about being person-centered, isn't it? And working out what's right for the patient.
Definitely. Yeah, getting a lot of thank yous for you. And someone is asking, what would you recommend if a person having some autistic spectrum condition comes to the pharmacy and she or he doesn't like hers or his new prescription?
That's interesting, because I used to work for the years ago for one of the CCGs, and I was a practice-based pharmacist. And at the time, I'm not sure if they still do a lot of this, but you know, sometimes you're looking at more cost-effective alternatives. And in this particular practice, in this area, the CCG, we were switching over high-cost branded statins to generic atorvastatin and simvastatin. And actually, because of my background, I was very wary of switching any of these. Anyone who I considered by looking at their notes and may have, say, autism or certain conditions like this, or maybe OCD, without having a consultation. And I think if something is going to be changed, actually, I think it's about having a conversation. But I think that's also having a conversation with anybody that's had their medicines changed. Because now some people don't worry, they say sometimes they're this colour, sometimes they're that colour. But I think as a pharmacy professional, you want to be talking to anybody. If you know that the brand has changed, and especially if you just need to speak to that person, because I think once you've had that conversation, then the anxiety level will go. Well, otherwise they get home, they find it's different, they feel anxious. And then, because sometimes it's just a conversation, it doesn't necessarily mean they won't change. So it's having that conversation and really it's applying to everybody.
Yeah, that's really interesting to hear. And someone else has asked, would you say it is easier to help people with autism in a hospital or community environment?
That's interesting. That's really interesting. I actually think there is probably a lack of awareness, probably from all of us actually, about how it's making assumptions, isn't it? About how, so in a mental health trust, often there's more, I think there's more awareness about autism. But I think a lot of other places now are coming on board. And of course, there is the new requirement at the Oliver McGowan campaign about, and the government have accepted that all health service providers will have to be have autism and learning disability training. So it is going to be changing. So although in the past that hasn't necessarily been the case, and I think it will be, but it's about being person-centered. If you're person-centered, you can work things out. So it's a busy community pharmacy. It may be at the end of the day, it's a quieter time. You find a time that, you know, that's the message, I think, about being understanding the person and understanding that they, you know, a busy, bustly pharmacy may not be, you know, may cause people to be anxious. A bit like Dave when he went into the pharmacy, you know, it can affect all of us. So.
Yeah. And I think there's one more question saying, how do you ask politely if the patient may suffer from a sensory challenge, so you're aware of like what's best to communicate with them? And I think that's quite interesting.
It's very interesting. I was thinking the same thing. I was thinking, because it is really difficult to know. I said it's much easier when you're in the education system, because, you know, people tend to know, or they might have a bit of extra time, or they have this very, very difficult. But then some people, you see, I was reading this morning, I was reading an article in a newspaper, and I don't know if you know Charlotte Tilbury, the makeup company.
Yeah.
I don't know, now Charlotte Tilbury is dyslexic. I was reading an article about her, and her son's dyslexic, and she's really proud of it. And she's talking all about the, you know, the skills they've got and all this. And that's one way. So some people are quite happy to share all this information, and they'll tell you, and other people, they'd be quite embarrassed about all this. And now, if somebody may have somebody with them, you may have, I think it's about establishing a communication. And if you've got a good relationship, you might ask if someone would prefer something. Would they prefer to come at a quieter time? Would they prefer? And then you might sort of gather. But it's very difficult, because also you can suspect someone has autism, but they may have not been diagnosed if they're an adult. Things are quite different, especially somebody that's sort of, you know, my age. The only thing people got diagnosed with at school would be dyslexia. You know, there was nothing else really. It's only in the last maybe say, you know, 20 years or so that it's really changed. So I think we have to handle it quite carefully. It's difficult to ask, because we've got all this information from today, and you're thinking, great, but how do I identify the patient?
Exactly.
So that's not so. I think it's having it at the back of your mind. And the other thing you might also think about, you might notice, for example, you might have a child's prescription for some ADHD medicines, and as I said, there's a lot of coexistence between these conditions. So it may be that the parent, you might think, oh, you might suspect there's something, you know. So sometimes one can suspect things because we understand there's some, you know, and there's a sort of a genetic link there. But I think it's quite difficult. Some people are very different, and I think you have to handle these things quite carefully.
Definitely agree on that one. And I think someone else has asked, can a child's coping with autism be worse when they are not diagnosed, especially at school? Will this have long-term effects on the child's mental health?
Well, I think if people often misunderstand autism, so I'll give an example. My daughter, when she used to go on the school bus, there was a boy on the school bus that wouldn't let anyone sit next to him. You know how on these coaches, they have like sort of seats are in twos. He wouldn't let anyone sit next to him. Now, she'd clocked there was a problem here, and some of the other boys were bullying him on the coach. She then found out it was a few months later, that indeed he had been diagnosed with Asperger's syndrome. So she said, well, that made sense. And but she said the problem was, of course, he hadn't sort of told, the other people didn't realize. So you can understand what I think, you know, if some people don't like to tell other people about it, and he hadn't told many people. I can't remember how my daughter found out actually, but she said it made sense. And then if she ever saw anyone starting with him on the school bus, you know, she'd sort of deal with it. But
So nice.
it's an issue there. You can see that, can't you, as a sort of how people just think, or I think Helen touched on this, it can appear that people with autism are being rude or difficult because no one realizes it's the fact that it's very noisy. The fact there's a smell has made that person very anxious. So it is difficult if people don't understand. That's why I think we've all got to be quite, people should be less judgmental, but that's an ideal world, isn't it?
Definitely, I agree. And I feel like, especially if you're undiagnosed, you might also just think that you're socially awkward, like not realizing that there's like an underlying issue, like there's a reason.
Well, it's interesting because we talk about the girls, and someone's just put on here something about girls, and that's a lot of the girls get diagnosed with autism. They get diagnosed with a mental health condition first. Often it can even be self-harming, depression, anxiety, and that comes first, or an eating disorder, because it's not picked up. So they can't understand why they are like they are. So they haven't got the strategies. So I think I think it's important to understand why. And they say having the naughty, someone's put in there about naughty schoolboy thing with ADHD. I mean, it's amazing that in clinicians I used to see this, and until quite recently there weren't even any adult services for ADHD. It was just sort of thought, oh, by the time they turn 18 and they leave school, oh, that's fine, it's gone. I don't understand how that was. I mean, I'm not quite sure if the only person that suited was the I don't know, the local health authorities didn't have to pay for services. I'm not quite sure where that came from, but there was this very sort of very old-fashioned idea. It's true, as people get older, they develop strategies, but yeah, so.
Definitely, it is true, because sometimes it might not be very healthy strategies, but it's just strategies to get through the day.
Yes, and it's understanding, and also and people can then make reasonable adjustments. I know Helen mentioned about reasonable adjustments as well, but I say if we can be as most inclusive as possible, then hopefully we won't have to make too many reasonable adjustments for people, and people are not made to feel different as well.
Definitely. I mean, this is the whole point of the webinar, to ensure that like as many people as possible learn more about autism, and just so, you know, to ensure that as we go into practice, we become more inclusive and more aware.
Absolutely, 100%. And it's not making the judgments. I think that to me the hard bit is we can understand the conditions, is how we actually put that into practice. And I'm hoping that I've given you some ideas about what to do. But I think a lot of ideas I've got really are just good practice with medicines and good practice with everybody, and not making assumptions that people know things, and just reflecting on your own thing. And I say, just reflecting in your own lives, you know, how would you like to be spoken to, and what do you need to know, what's important to you?
Definitely. And I think we've got one last question that says, how can we be more aware of the services available to support people with conditions such as autism?
That's a very, very good question. And in fact, signposting from a community pharmacy's perspective is really important in all areas of clinical practice. And so I think what's really important actually is that is knowing, is finding out. Sometimes it might just be a case of Googling. It might be the National Autistic Society will have a local group, and that's probably a good place to start, is to find out about that. So because I think, I mean, if you there's some of those websites, and some of there's organisations for learning disability and for autism do have information about medicine. Some are good, some are not so good, and other healthcare perspectives. But yeah, you can find that out. A lot of these things are readily available on say Google, but say National Autistic Society is a good one to start with.
Definitely. And I think even Helen's talk, because she's like the head of the I Am Celebrating Autism in Greater Manchester. So, you know, if any of you guys become pharmacists in Manchester, that's another service to like refer to.
Yeah, so I think and I think community pharmacy, pharmacy is the most accessible health resource on the on the high street. We can just walk into a pharmacy, can't we? Whereas you haven't got to make an appointment. It's not so. It's we're easily accessible, and if we can provide people with information, I think that's great.
Yeah, definitely. If anyone has any more questions, if not, then I guess we'll move on to the applications. So if you guys have any questions, now's the chance. Ask away. It's a great opportunity. You've got two great speakers.
Actually, someone's just put something up there that's actually quite interesting, is that, of course, general support groups for parents, actually. And yes, I didn't mention that. It doesn't have to be autism specific, because sometimes there's some really good support groups in some areas.
That's a good one. I guess there's no more questions then. Well, thank you very much, Danielle, for like giving your time. I understand that you're at the moment, you're also doing your PhD, so you might be really busy at the moment. And thank you so much, for giving your time and to actually like helping us learn more about like practice of like how to actually apply the knowledge that we've learned like earlier from the other two talks into practice as pharmacists. Oh, I think there's one more that says, how would you address someone's fears of having issues within the healthcare system, whether due to existing prejudices or miscommunications?
That's a long question.
Yeah,
That's a big
that's a big
question.
question.
Yes, that is a big. I mean, one of the things I think it's important, as I said before, keeping a record of their medicines. If somebody has I think it's like equipping people and empowering people so they understand that they can, there's the shared decision-making agenda, and making sure people understand that they do, and also they may want to have an advocate. It may be that they need to contact an advocacy group. So I think I think if from the pharmacy perspective, if you can make sure they know exactly what's happening with their medicines, they know what they're on, they can feel empowered in that way. And then it may be that they need, so is it maybe advocacy, maybe what they need, or they may want to take someone with them. So it's difficult because that's a difficult question, because I think, unfortunately, not all practice is optimal within the health service. Shall we say that? And if people have not necessarily experienced good quality care, that's not great. So, well, let's hope that sort of changes with the changes in the with when people have the mandatory training.
Definitely, I definitely agree on that one. I guess it's 8:20 at the moment, so I have promised anyone that has wanted for BPSA applications, so I'm going to give them that 10 minutes if they have any questions or queries. But again, thank you very much, Danielle. I really enjoyed the talk personally, and I'm pretty sure that everyone that attended this webinar has very much enjoyed it and has learned so much from it, and hopefully we'll all be able to like apply this all within practice in the future.
Thank you very much.
Thank you.
Okay, bye then.
All right, bye. Thank you very much, Dave,
Bye.
again. Bye. All right. So if you guys have any questions about, I don't know, so you guys all must have received emails by now about like BPSA liaison applications and BPSA representative applications. So I know in the Pennine area, an update that would be Manchester, University of Manchester and University of Huddersfield have a liaison at the moment. So if you guys have applied to that, unfortunately, we won't be accepting them as they already have liaisons. However, you guys can apply for rep applications in Manchester and in Huddersfield. And for University of Bradford, University of Central Lancashire, and Liverpool John Moores University, and Keele University, they have liaison applications open and representative applications. And I'm gonna put up the link in a moment, but if you guys have any questions about the application or about the role, ask away. And would you guys, and also I think for this year, oh, well, I'll put up the link just now. So this year, the BPSA liaison application, well, the role has changed quite a bit in that you will have more responsibilities. And in a sense, you could see I see it more as like a taster session of what it's like to be an area coordinator. So if you basically be responsible over like the 4 representatives in your university, and you'll be responsible for sharing. Yeah, that's the link I put in the chat box. But basically, you'll be responsible for sharing content, doing promotions about events like this, and also, sharing about competitions. So you'll also be working with the competitions coordinator and helping them do promotions and do sharing. And basically, you're kind of like the area of contact, like for the BPSA from your university. And you will be working with me. So hopefully, you'll be running workshops and running your own version of events. So yes, so the BPSA representatives, it is mainly about communication, sharing information. So you'll be working with me, the area coordinator, and the liaison into like doing promotions, sharing it, and basically trying to reach out with everyone within your year. And yeah, the registration slot, you haven't received the email yet. You should receive an email. Maybe you should receive an email for like your certificate later on. If not, then try registering again. And I hope that's given you guys like a bit of informative information about what it's like to have the roles. If you guys have, no, it doesn't matter. So for liaison, you can apply whatever year you're in. I know University of Manchester liaisons are first years, and they're doing a great job at the moment. They've been doing a lot of sharing, a lot of promotions. And you can even, if a liaison might be like too much for you, you can also apply just to be like a representative for your year. So each year has their own representative. Oh. Yeah, I mean, if, well, for part of the LPSA, there will be more BPSA events. That I am not very sure. I will leave that question to another member of the executive here to answer. What are the benefits? I mean, you can add that to your CV. It's great experience that you can apply later on. You know, it's a great example if you go into an interview for a job or for maybe another role in the future, you can talk about how you've been really involved as a representative or a liaison. So are there any questions? All right, so like I said, so what representatives do in a nutshell is mainly basically share BPSA stuff and do promotions. And it's kind of like a stepping stone up. So if you want to apply for other BPSA roles in the future, it sort of is a starter and it's a good way. And you are more involved within the BPSA as a representative. So it's not really, you don't really have that much to do, but it's a good start. Yeah. So for the LPSA one, basically all universities, if you're a member of your like, sorry, 1 minute. If you guys have any other questions. Oh, Anna Maria has raised her hand. If you have any question, Anna, you can just write in the chat box. Right, well, if there aren't any more questions, then I guess we'll end the webinar in 3 minutes. 3 minutes time. Just a moment. The certificate, you won't receive the certificate now. So basically, because we need some time to like process everything, but you will be receiving a certificate soon enough. So you'll get emailed on that. And I think another member has shared like links to other events coming up. So we've got a webinar coming up next Wednesday. It's with Reckitt Bennett, Ben Kisser. I am horrible at pronouncing, sorry you guys, but the title is about let's talk gastrointestinal. All right, it's a great time. It's almost Christmas. We're gonna be eating a lot. So, you know, this is a great talk to attend to, helping our digestive system. So I'd really recommend going to that one too. We've also got a bunch of other, so we've got our social media websites written on the chat. Anyone interested, give us a follow, give us a like. I know we're doing self-clout here, but you know, it is a BPSA event. So if anyone has any questions,